Hello everyone, a very warm welcome to everyone in the part 1 video of the thyroid carcinoma. Here we begin with introduction, pathogenesis, morphology of papillary thyroid carcinoma. And before going to the papillary thyroid carcinoma, we see the major subtypes of the thyroid carcinomas. First, we see papillary thyroid carcinoma, which could be conventional and encapsulated follicular variant, and this contribute to 80 to 85% of cases of the thyroid carcinoma. And the second is follicular carcinoma, which contribute for 10 to 15%. And poorly differentiated are anaplastic and differentiated carcinoma, which contribute for less than 5% cases of the thyroid carcinoma. And next is medullary carcinoma, which account for 5% of cases of the thyroid carcinoma. These are the various subtypes of the thyroid carcinoma that we will discuss one by one in different videos. And most of thyroid carcinomas are derived from the thyroid follicle epithelium. But this medullary carcinoma is the only thyroid carcinoma that is derived from the parafollicular cells. And the precursor agents to these thyroid carcinomas could be like the for conventional papillary thyroid carcinoma, it could be papillary microadenoma, and various non-invasive thyroid neoplasm with papillary-like nuclear feature that could be precursor to the invasive encapsulated follicular variant of the papillary thyroid carcinoma. And non-functioning follicular adenoma could be the precursor to the follicular carcinoma, and similarly the well-differentiated follicular thyroid carcinoma or follicular carcinoma with acquisition of the additional mutation give rise to poorly differentiated and anaplastic carcinoma. That means these poorly differentiated and anaplastic carcinomas are the uh, derivation of the well differentiated papillary thyroid carcinoma or follicular carcinoma only after the acquisition of the additional mutation. Now, introduction to the papillary thyroid carcinoma. This is the most common form of the thyroid carcinoma, as we discussed earlier, that it accounts for 80 to 85% cases of the thyroid carcinoma. So this one is the most common form, and this occur throughout the life, but most often between the age 25 to 50 years of age, and majority of cases are associated with exposure to ionizing radiation. And pathogenesis of this papillary thyroid carcinoma uh, could be there could be two genetic abnormalities. First could be the translocation resulting in the gene fusion of the RET or NTRK, and that happen in the 5% cases, where there is the RET gene present in long arm of the 10th chromosome in its 11th band, and that encode for RTK, not normally present in the thyroid follicular cells, but after the fusion these may present in these thyroid follicular cells, and that will result in the growth signaling. And this papillary thyroid carcinoma rearrangement involving RET create fusion genes encoding constitutively active forms of the RET tyrosine kinase, and there are more than 15 fusion partners of the RET, and the two of them, like PTC1 and PTC2, are most common. And NTRK gene, which encodes receptor tyrosine kinase on 21th band of the long arm of the first chromosome, or one chromosome number 1, and there is the paracentric inversion or translocation, which results in the uh, you know presence of this RET tyrosine kinase in the thyroid follicular cell, which results in providing the signal for the growth of the follicular cells and results in papillary thyroid carcinoma. And these arrangements drive the cell to grow and divide uncontrollably. And next is gain of function mutation in BRAF gene, which is contributing to 50% to 80% of the cases of the conventional papillary thyroid carcinomas. And this BRAF gene mainly encodes serine threonine kinase, which is called as a BRAF protein in growth that has a role in growth factor signaling pathways. And there is a mutation in this BRAF gene, and this BRAF protein, which is serine threonine kinase, that provides instruction to RAS and MAPK signaling pathway, which regulates the essential cellular processes like growth, division, differentiation, and self-destruction like apoptosis. So, if there is a mutation, BRAF V600E mutation, that is the amino acid valine at position 600 is replaced by the glutamic acid E that results in constitutively active form are always on BRAF protein, and this send constant signals for the cells to grow and divide, and this results in uncontrolled cell growth and contribute to the development of the thyroid cancer. And this BRAF mutation can also be found in melanoma, hair cell leukemia, colorectal cancer, and the presence of BRAF mutation in conventional papillary thyroid carcinomas is associated with reduced expression of the thyroid differentiation markers like thyroglobulin and thyroid peroxidase, which are generally tested by collecting blood from the patient. And such types of marker of thyroid differentiation are generally reduced in this, but if such things are present, then that signifies the follicular carcinomas, which we discuss in follicular carcinoma. And there is a higher risk of extrathyroidal extension and recurrence in case of papillary thyroid carcinoma, which is caused by a BRAF gene mutation. Now we see the morphology of the conventional papillary thyroid carcinoma. First we go through the gross picture. This is the solitary or multifocal it could be, and well circumscribed, while others may infiltrate the adjacent parenchyma, and you have if there is infiltration, then there will be ill-defined margins, but otherwise it will be well circumscribed. Here we can see papillary carcinoma with the cystic changes, various cyst-like formations in this affected region, and papillary forms visible grossly, and the solid area of tumor can be also seen here, and the tumor contained area of fibrosis and calcification, often cystic. Changes can also be appreciated, and papillary microadenoma, otherwise called as papillary carcinoma, only the difference is that its size is less than 1 centimeter. Next, we see the microscopic picture of this conventional uh, papillary thyroid carcinoma. Here we appreciate there is a fibrovascular core and oval nucleus and nuclear groove and intranuclear pseudo inclusions. Such inclusions are very diagnostic feature of this um, thyroid carcinoma, and papillary architecture with the fibrovascular cores are appreciated here, and the optically clear nucleus, and there is a presence of the samoma bodies, that is a calcified spherules, that is a spherical structure, that is a samoma bodies commonly in the stroma of the papillae. And papillary is a slender or finger-like projections of the fibrovascular course, and that is lined by the tumor cells. And this fibrovascular stalk covered by the single or multiple layers of cuboidal epithelial cells, and epithelium covering the papillae consists of well differentiated uniform moderately placed cuboidal cells, and in a plastic, but if it's in a plastic, then there's so variation in the cell and nuclear morphology, but if the in a plastic nature is not present there, and there is a well differentiation of the cells than the orderly placed cuboidal cells are present. But in case of epithelial and plastic cells, there is the variation in the cell as well as in the nuclear morphology. And nuclear feature can be like there will be empty or pale appearance due to finely dispersed chromatin, and that often called as orphan any eyes appearance or ground glass nuclei. Such things can be seen here. And next is the microscopic feature of the papillary thyroid carcinoma. There is a nuclear growth, and this is the longitudinal growth on the nuclear membrane that results from the convoluted nuclear surface and the nuclear pseudo inclusions. What happens that this is a cell, and in the shell centrally there is a nucleus, and if these cytoplasm get invaginated to the nucleus and later on that is surrounded by the nuclear membrane, so this nuclear bound cytoplasm present in the nucleus that will form the structure that is called the finger-like projections of the cytoplasm that fold inward into the nucleus, and this is called an island of the cytoplasm seen within the nucleus that is limited by the nuclear membrane. And samoma bodies, that is the concentric laminated calcified um, spherical cluster of the calcium deposit having a layered onion-like appearance typically found within the fibrous structure of the tumor's papillary. And the nuclear overlap. The tumor cells may overlap significantly without clear borders and feature easily seen at the lower magnification. This much for now. Thank you for having your patience.